Hi everyone, Dr. Michael Miyazaki again. Thank you for joining me. This has been a long week. It was a good week, but it was a busy week. So what I wanted to do today is just kind of show you that I do practice what I preach. The things that I discuss during these programs, I actually do in my own practice. So I work 4 days this week, Tuesday through Friday, have my Mondays off. And today when I'm recording this, it is Friday afternoon. So we just got done with the week. And it's one of those TGIF moments. But it was a fun week. And what I want to just discuss with you is a little bit about tissue management and the way I work the endodontics in the practice. One of the reasons why is because I've talked many times about QuickStat Free. QuickStat Free is my go-to hemostatic agent, whether I'm working in the back of the mouth, where it doesn't really matter if I've got dark tissue, or the front of the mouth where I don't want to see that stained tissue. QuickStat Free, I find, just works really well. And yet, I talked to some clinicians who let me know that, hey, I've tried QuickStat Free and I love it too. And then I've talked to other clinicians who tell me that they've tried QuickStat Free and it's not working well for them. So one of the things I want to discuss was the use of QuickStat Free in your tissue management, and just show you an example of a case that I had yesterday. And let me just get into this part of the program. Here we have on the distal area of that first bicuspid, upper left first bicuspid, we've got a large restoration, and you can see that it looks like the margin is leaking down at the gingival floor margin. And so I saw this, and we saw how big it was, and we actually advised the patient this tooth might actually even need a root canal because the decay is going up underneath this large restoration, and we can't really tell from an X-ray exactly how close it is to the nerve of the tooth. So we look at this case, and when you look at this radiograph, you know you're going to be pretty close to the bone. You will be subgingival. So I had my QuickStat Free ready to go. And as I got into this, I advised the patient, we might need to do a root canal, we might need to do a crown, but I'm going to go in and clean this old restoration out, and we'll see what we have. So as I got in there, you could see it was very hard to see because the decay was below that restoration, and it was a fairly deep restoration as far as being subgingival, and all of a sudden I have the dreaded red. And that dread red really makes it hard for me to even see, am I far enough down there? Is there still more decay? What's going on? So now what I do is I take my QuickStat Free. Again, it's the only hemostatic agent I use today. And I don't scrub it into the tissue like we've been taught with some of the other hemostatic agents. You got to scrub it, and then maybe rinse. And if it's still bleeding, scrub it, and rinse. And if it's still bleeding, scrub it again. With the QuickStat Free, it's also an astringent, and so what I do is I just use my StatFlow tips and I just apply it to the area of the tissue that's bleeding, but I don't really scrub it. I just apply it so I deliver it to the tissue. I deliver it to the broken blood vessels. And QuickStat Free is different because it has aluminum chloride, it has magnesium, and it has those surfactants. And the surfactants help the QuickStat Free penetrate into the broken blood vessels. And so I just rub it up there. I don't leave it for a minute or two. I just rubbed it up into that area that was bleeding. You saw at the gingival floor. And then I rinse it out. And I rinse with water, and I just tell the patient, hey, I'm applying a medication to the gum because this decay was below the gum line. So as I'm removing the old filling and the decay, the gum's bleeding a little bit. So I'm just going to apply this medication to stop the bleeding. It may not taste good, but I will tell you, I really haven't had patients complain about the taste, and I rinse it out and I dry it. And what you can see at this point is if I was working around a crown prep, I might go ahead and take my impression or do an intraoral scan. I need to have that area dry. I can't have saliva in that area if I'm going to do an intraoral scan. I can't have blood around that area if I'm going to do an intraoral scan. If in this case it turned out we were just going to place a direct composite restoration. And you can see how well that dries everything up. Now I can see, do I need to go back in there and remove some more of the restorative material? Do I need to remove some more decay? I'm going to finish up my line angles and kind of smooth everything up. But we went from that bloody mess to now having it nice and clear, and I can actually get in there and refine everything. That's what I love about QuickStat Free. QuickStat Free for me works like this. You've seen some of the other videos we've posted where I had a ton of bleeding. I take my QuickStat Free, and again, I don't scrub it into the tissue. I just apply it to the tissue, and then I rinse it off. If I'm using a cord, as I showed in one of the last programs that we did, is I put my QuickStat Free onto the cord. I use the QuickStat Free as like a lubricant, so I can slide it down into the sulcus better. And the QuickStat Free gives me my hemostasis, and I let it sit there for a minute just to stretch the tissue out. Then I pull the cord and I take my intraoral scan or my impression, whatever it may be that we're doing. But to me, this is the kind of result that I get with QuickStat Free, where we will go from that heavy bleeding, pooled areas of blood, apply the QuickStat Free, rinse it off, and now I can see whatever I have to see. So in my hands, QuickStat Free works very well. And I'm just trying to figure out how I can convey the technique of using QuickStat Free so you all can enjoy the same type of success. So bloody area, apply, don't scrub, apply the QuickStat Free to the areas that are bleeding, and then rinse it and dry it, and you should have great success. So that's what I'm experiencing clinically. So when I tell you that this is the only hemostatic agent that I use, I'm just telling you the truth. I'm telling you from what I see clinically. QuickStat Free for me works great. So I just wanted to explain that from a tissue management aspect. And then some of the other things that I've shared with you is that today, with the endodontic techniques that we have, the instrumentation, the irrigation, the activation, everything that we have, our endodontic procedures are so much more predictable. So I often do this. These are two cases that I did this week. I often do my endo and my restorative all in one visit. So this patient came in. You could see that she had broken off the buccal cusp, had broken off half of the buccal portion of that tooth, and it's been like this for a while. Last time I saw this patient's been a patient of ours now for about 30 years, but the last time I saw this patient was probably 15 years ago or even more. And she said she's just been busy, hasn't had time to take care of her teeth. So she comes in and she goes, can you take care of this tooth? Because when she smiles, she sees this area. And, aesthetically, it's just not very pleasing. So we went through what our alternatives were. We could take the tooth out. We could do a bridge. We could do something removable. We could do nothing. Or we can place an implant. Or I told her, I said, we could try to restore this tooth. My concern was that the portion of the tooth that was left on the lingual half of the tooth was soft. There was decay. You could see that brown area of decay. So I was really concerned when I got in here to see how strong the tooth was going to be in this area. So we discussed the possibility of doing a root canal, core buildup, and a crown. So I got up in there. We did our rough prep. We got in there and we cleaned out this area right there where it was really soft. I could scoop all that tooth out. But I'll tell you, the core of the tooth was pretty good. It was intact. We got in here. This is actually the access to the lingual canal right here. The buccal canal was down over here. So we went ahead and we did our root canal procedure using a reciprocal system, a one resi system. And we gained our access. Now, why one resi? Because it's a minimally invasive type of shaping that we can do with the one resi. So in this case where I don't have a lot of tooth, I wanted to conserve the tooth structure that I had. Here is our gutta percha try-in, make sure that we were lengthened, that I had the two canals. And then here is our obturation and fill. And you can see that because of the infection of the apical area, there was a little bit of overfill, but I used the bioactive sealer, so I'm not even worried about it. Why did I feel comfortable doing this in one visit? One, the instrumentation we have today is just so much more predictable and so much faster. We can get things done much quicker than we could ever get it done before. The irrigation, I'm using the advanced irrigation so that we can dissolve the tissue, we can get rid of the bacteria, I can remove the smear layer, and when I go to fill this and obturate it, we're going to get good adhesion to our canal walls. As I'm irrigating, I have the activation. I use the Endo Ultra. I have ultrasonic activation. So I'm not just putting my irrigant into the canal passively, but then I'm activating it with the 35,000 to 40,000 hertz of activation. That is going to get my irrigants to work faster and more efficiently. It's going to remove the dental mud, and it's going to give us much better success. In this case, I use the Chlor Extra, which is the sodium hypochlorite, 6% with the surface modifiers, so it works faster, it dissolves the tissue faster. Then I use the EDTA to remove the dental mud from the canal walls, and then I go back in with my Chlor Extra, my 6% sodium hypochlorite advanced irrigant to clean out the tubules that are opened up when I remove that dental mud. I'm using activation for both of these to make sure that we get everything out. Then when I seal this up, I'm using the Regen Bioactive Sealer, Endodontic Sealer, to seal these canals up. What it does, if we do have an overfill up there, it's going to create an alkaline environment. So I saw this patient after this was done this week, and she complained of no discomfort at all. Why? Because it creates an alkaline environment up where the infection used to be, and so there's very little discomfort. Why do I restore? Because one of the things that can happen is we can do the perfect root canal, and if the tooth is not restored, one, the patient could bite on it, could fracture off more tooth, or bacteria could get through our gutta percha and a sealer and get back into the apical area of the tooth and cause a new apical infection. So what I want to do is I want to restore the tooth to preserve the tooth structure so the patient can use the tooth, can smile with the tooth, gain the aesthetics, but that we can restore the strength of the tooth and then seal the access up so bacteria can't go up through our obturation material to get back in the apical area. When the patient saw this when we were done, she was thrilled. She had been working for how long, smiling, and you could see that first bicuspid, and she hated it. We gave her tooth back, and she was like, wow, I can smile. I don't have to feel self-conscious about my smile anymore. She was thrilled. I saw her today, which was a few days after we did this procedure, and she was smiling. And it was funny, when I talked about this. When we do a smile makeover, patients will say, well, I love my smile, and they'll thank you for everything you did. And I've mentioned that patients typically won't mention, thank you for that root canal and crown. But this patient, when she came back in, she said she was thrilled by the end result. And again, no discomfort, and she had her tooth, and she had a smile. So how do we create the success? I use Chlor Extra, 6% sodium hypochlorite with enhanced surface modifiers and whitening agents. I put the Chlor Extra and the EDTA, which you see on the far right-hand side, I put those in color-code syringes. So the Chlor Extra goes in the red syringe because the red band is on the Chlor Extra bottle right here. And then the blue syringe we use for the EDTA because EDTA has the blue band on it. As I'm irrigating with these syringes, I use the VIP tip, 29 gauge tip. Why? Because it's a dual side port syringe. It can't go out the apex area of the tooth, the apical portion of the tooth. And I will tell you, today when I was irrigating doing the root canal, I could use 20 milliliters of irrigant, and my hand could easily express the irrigant through the VIP tips. I wasn't shaking or worried about jamming it up into the apical end of the root canal system and expressing any of the sodium hypochlorite out the apex. So with the dual side port, we shouldn't be doing that. I take that VIP tip, put it into the bottom of the canal, gently express without binding at the apex of the canal, and I gently express out my Chlor Extra, my EDTA, whichever one I'm using. I use the Endo Ultra, which has the ultrasonic activation inside of my irrigants, my Chlor Extra and my EDTA, to activate it, to clean out the canal even better. And then when I was done, we used a bioactive endo sealer, which is the bioceramic root canal sealer from Vista Apex. Now this is very affordable. It is a value material. It's a very good material, and it isn't astronomically priced. It's a great value. But to make it even better, we had the material savings tip so that you don't lose a lot of the bioactive sealer, the endo sealer, in the hub of your needle. So the MST tips that come with your bioactive endo sealer help to make this an even better bargain. So why do we have such great success? Because we're using a great system of instrumentation, the One Resi. I've got these advanced design pharmacy controlled irrigants. These irrigants we can't mix up. It's safer because I've got color coded syringes. But as I'm using the irrigants, I'm delivering it to the canal system with the VIP tips because we have the dual side ports, so it's very easy to express out of the needle into the canal. And then when I get the irrigants into the canal, I use the Endo Ultra to activate it. We then will lightly dry everything, use the bioactive sealer with a single gutta percha point to obturate the canals, and we have great success. I will tell you, this is how I do the majority of my root canals. Is I will get the patient in, numb them up, do the root canal, and create the final restoration if possible during that same visit. So it works great. Doctors have asked me, well, how do you do that? Well, what I do is I take the tooth, I prep it first so I have good circumferential margins. If I have to do a core buildup, what I'll do is I may block out the core area if the tooth is missing in that area, the tooth structure, or I will let the restorative material fill in the core. Let's say I'm doing an Emax crown or zirconia crown. I'll have the crown, and the underside of the crown will have the core attached to it, right? So it's going to be super strong with a lot of great retention, and then I'll just bond the whole thing in. So this, again, is the type of predictability we can get. If you go back and you look at all the YouTube programs that we've done, you know, we've given you tips after tip after tip of how to use the different materials and how to gain this kind of confidence in your endodontic success and your restorative success. So I use a Chlorextra 6%, and then I use the EDTA 17%. Then we use the color-coded syringes that have the VIP tips attached to them, so we can use a dual side port to get the irrigants safely into the canals. That irrigant, then we do activate it with the Endo Ultra cordless ultrasonic activator, and then we use the Regen Bioactive Endo Sealer with the MST, the material saving tip. And I like the stainless steel tips because I can get them into the canals easier, and I can kind of feel where I am in the canals. And what I'll do is I'll start expressing it gently, and as I express it, I will withdraw it from the canal. And then gently I'll take a single gutta percha point and I'll place that into the canal and just gently place that in. So I don't not want to have a puff, but I try to minimize the puff that we get at the very end. So I'll just gently place the sealer, withdraw the tip so I'm not expressing it out the apical end, and then I gently place the gutta percha so that, again, we try to minimize what we express out the end of our shaped canals. So here is another tooth that I just saw this morning. What I'm hoping is that this bone loss in the furcation, this is a lower left first molar, it has an endodontic origin, not a peri origin. So my feeling is that if we can take care of the endo abscess, that the bone will regrow into that furcation. So I've warned or advised the patient that we have to see how this tooth heals up. So we're going to do the endo first, allow this to heal up, and hopefully we'll see the bone grow back into that furcation over the next few months. So you can see we go through it. We're instrumenting this. Again, I use the one Resi system for this. I get down to the apex, third photo from the left. You can see we've placed our gutta percha, single point gutta percha with our bioactive bioceramic sealer. And on the right hand side, you can kind of see how I've colorized it. So you can see that we're all the way down to the canals. I irrigated this out really thoroughly, and then we were able to deliver the crown. So this is the type of predictability that we hope that you can all enjoy today with the instrumentation we have, with the irrigation, irrigants, and the activation that we have. We can clean those canals out very predictably. We seal the canals up with a bioactive sealer that is very not cytotoxic, so it's very kind to the tissues around the apical area of the tooth, so we don't have any kind of post-op sensitivity or any kind of sensitivity after the root canal is done. And then we place the restoration. So everything is restored, like you see over here on the right-hand side. The patient came in with that large lingual side of that tooth fractured off, and on the right-hand side, you can see that now the patient comes in, the root canal is done, and the restoration is in place. So Again, we are creating this community of like-minded clinicians trying to do the very best that we can for our patients. If you like these videos, hit the like button. If you don't want to miss these little programs, information of what I'm doing in my practice, hit subscribe, please. And if you think somebody else would like or could enjoy watching this information, share it with a friend. But again, in this episode, I just wanted to show you that I am practicing what it is that I preach on the tissue management and endodontic treatments that we're providing to our patients in our practice. So again, I hope this helps you understand how I'm approaching these treatments. I hope this makes your clinical life easier, and I look forward to seeing you during our next program. Take care.